Welcome to World Medical Elites. This is Shirley Crest Studley, and today we will be discussing preventative medicine with our guest, Dr. Ford Brewer. Welcome, Dr. Brewer.
Well, thank you, Shirley, for having me on. I'm excited to be here.
Oh, great. Dr. Brewer is the founder of Preventive Health and is a board-certified preventive and occupational medicine physician, an internationally recognized speaker and educator. He learned early on in his career, starting at Johns Hopkins University, that many disabilities and diseases brought to the emergency department are preventable. He has since dedicated his career to help spread knowledge about how to prevent the most common chronic and debilitating diseases, such as type 2 diabetes, heart attack, and stroke, as well as improving patient care by educating healthcare providers. Dr. Brewer, what inspired you to found PrevMed Health, and what is your overall mission?
So thanks for asking. I started off as an ER doc. I wasn't sure what I wanted to go into. And ER was a lot of fun. It was exciting. And as you know, since my days in the ER 30 years ago, they've started to make television shows and movies out of it.
Mm-hmm.
So it can be exciting. But here's the problem. After the countless heart attacks, strokes, trauma, bad things happening to people and bringing them into the ER that just coulda, woulda, shoulda been prevented either for 2 or 3 decades or completely, you get very frustrated with what's going on in medicine. And one of the things you realize is that somebody's healthcare is different, but somebody's health is really much more of a function of what that person does all day, every day. What they eat, how much they eat, when they eat, how much they sleep, how much they work out, how they work out. Just tons of things, whether or not they use substances and drugs, it's just true health is really more of a lifestyle issue. So when I was growing up, I grew up in the deep South, South Carolina. And one of the things that I felt like I really didn't want to be was a teacher. Not so much because I didn't like teachers, but because I felt like, the kids in my class didn't listen and I didn't either. So it just seemed to me like a tough job. After treating all of those heart attacks and strokes where these patients, their brains were injured, their hearts were injured permanently, I began to look at teaching in a different light. It's like, what? Is this about me and making money and having, and being excited at work, or is this about the patients? And if it's about the patients, then, I need to go back and reconsider what I was doing. And that was the point where I said, you know what? Okay, I'm going to bite the bullet. I'm going to I'm going to see what I can do in prevention. At that time, and still even now, 30 years later, Johns Hopkins is by far the biggest place, the most respected place in the world for prevention. I wasn't even sure that I could get in, but I did. I loved it. I did very well there and ended up running the program. I took over the postgraduate medical programs for training other doctors who were coming there to learn preventive medicine. And I've not looked back. I have, there are times, especially early on in my career, where I felt like, dang, it's frustrating. Guys like me make the real big impact on public health, but it's cardiothoracic surgeons and other guys that do technical procedure kind of things that really make the big bucks. And, that was frustrating, but it was what it was. And it was more important to make an impact on health than to make a lot of money. Things have changed over the past decade or two. Medicare, other big payers have always tried to figure out ways to get primary care docs back into a place where they are actually engaged financially and they make financial benefit from the whatever benefit they're creating for their patients. And that is a major change in the way healthcare is being delivered and paid these days. So I couldn't be happier. All I wish is that this had happened 30 years ago.
Mm-hmm. Could you tell me a little bit more about your team, their expertise, and how you approach preventative care?
I'd love to. So I've got Dr. Vega, Jesus. First of all, my whole team is digital. Um, I've been a national corporate medical director for a lot of different companies. Kroger, for example, believe it or not, Kroger has a national operation. It's called the Little Clinic. I was the medical director for there. I was the medical director for Toyota for all of North America, then the Western Hemisphere. I was the medical director for for a company called Physician Partners, 150,000 patients in this new fee-for-value space. Premise Healthcare, which is, gosh, they're a couple of billion in revenue now. We grew. I joined them when we were like 25 million, and very, very big at this point. They provide on-site health care, Premise does, for a huge portion of the Fortune 500. So if you're looking for an employer that's got thousands of people on site, that's what Premise does, on the premises or on-site healthcare. But Stuart Clark and I talked many times back when I was at Premise, and one of the things we said is, our business model right now is on-site healthcare for large populations. The reality is, once the public wraps its head around digital or remote access or telemedicine, telehealth, whatever you want to call it, it's going to it should just rewrite the book on healthcare access.
So you say your entire team is online, is digital.
Correct. So we've got, just to connect those dots, be careful what you ask for. I suffered for years trying to get this telemedicine revolution started, and all it took was a pandemic. Now everybody's gotten used to getting telemedicine, getting their healthcare online. Now, my team it consists of a couple of groups. It's the healthcare group, which is Dr. Vega, myself, James Santolo, and Miranda. Now, Miranda's a physician. Jesus is a physician. They both got some preventive medicine background. They both have worked in the spaces where I work. Jesus is a well-trained preventive medicine doc, also an occupational medicine doc. He does not practice as a doctor with us. He practices basically as he manages our CCM, chronic care management program. Miranda is doing a combination of those types of activities, CCM, chronic care management, AWV, annual wellness visits. And if you've been in the Medicare world very long, you might recognize some of the terms that I'm using, CCM and AWV. James Santolo is a very good RN. He's in the Boston area. He's got great communication skills, meaning he listens. And he is very much involved in our CCM programs. The CCM, chronic care management, is a way, it was originally developed by Medicare, and it's a way to have patients connected to their doctors' healthcare teams. So every day or 3 times a week, depending on what the patient's got an appetite for, we'll send them some questions and ask them, okay, how are you doing today? Are you having any symptoms? Are you, most of our patients have one form of prediabetes or another, or high blood pressure, or one of the other chronic diseases. So we ask them some questions about their specific disease. It doesn't take long. They've actually timed it, and it takes an average of 40 seconds for a patient to answer these questions. What Medicare has found, and what's been proven multiple times now as you start watching that program, is that people that actually participate with their physician's medical team in these programs are much healthier. And here's what Medicare gets out of it: because the patients are healthier, they end up not going to the hospital. So Medicare ends up missing out on a few $250,000 hospitalization visits. Well, it only takes $250,000 hospitalization to pay for a heck of a lot of CCM. So that's a little bit about our digital healthcare team and what they're doing, how they work. I mentioned two teams. The other team is our content team. We have an active YouTube channel.
Do you also have lifestyle and wellness coaching, I believe?
Yes, we do.
Can you tell me a little bit more about that?
Sure. We've got Dr. Derricks. She has a doctorate in health education from Johns Hopkins and a doctorate in or a 3-year postdoc from Vanderbilt in health coaching. We've got a couple of other health coaches as well. And it's interesting, when I first started this program, I had said to Janice, look, the reality for this, given the fact that health is driven by people's habits, their health behavior, and more so than any prescription that a doctor can write for them, my role is as the chief health counselor assistant, the chief health coach assistant. Mm-hmm. That's not the founder, not the medical director, not the doc, but as an assistant to whoever's helping the patient work on their behavior.
So how do you coordinate with other healthcare providers like primary care physicians or specialists?
Well, that's an interesting question. So a lot of our patients come on board and they ask the same question. They say, well, I have primary care. How do you coordinate? And a lot of them come on and they're nervous. They feel like they're cheating on their primary care doctor. And it's kind of funny because, you feel comfortable going to see a cardiologist. You feel comfortable to go see an orthopedist, but you don't feel comfortable seeing a prevention specialist. A whole lot of that is because so few people have gone into prevention. And, it's just another problem with healthcare and healthcare manpower and the way it's set up. Of the very few people that actually go into prevention, very few of them go into what I do, actually helping people with their health. You get tons of people that go onto the internet and they basically tend to sell supplements, not really that kind of prevention. Of those that get the actual training and the technical background in prevention, most of those end up going into public health work and end up running public health programs. So you have very few people that actually help patients add healthy decades to their lives.
Interesting. Well, can you walk us through a typical patient journey from initial consultation to ongoing care?
I'll do it. So these days, most of our patients come in from the YouTube channel. I mentioned it a minute ago. We've got 125,000 subscribers. And I started it basically thinking, you know what? I can be a little bit techno geek in terms of medicine, but I'm still sure that there'll be a lot of patients and maybe even a lot of doctors who are interested in that. I had just come home from it was a $2,500 training on cardiovascular, specific to some cardiovascular prevention. Again, $2,500 for a weekend, and I'm thinking, that's it's expensive. I understand why docs pay that kind of money for CMEs, continuing medical education, but none of this stuff, this is public information and people have a right to it. And you know what? There's this new thing called YouTube, and I'll just put a few things out there and see how it goes. I didn't know the technology very well, so I would just print stuff off and hold the paper in front of the computer while I was talking to it. And I got a lot of grief for really, really bad technology, but the
Mhm.
content won folks over. And so most of my patients come in now through the YouTube channel. About half of them come in and they're already in good shape. And, I'll ask them, have you lost weight recently? Oh, yeah, I lost 30 pounds. I lost 75 pounds. I had a guy a couple of months ago. Yes, I've lost over 150 pounds.
Oh my goodness.
And
Oh,
it's interesting when I ask them, so how did you lose weight? And you see a pattern there. And it's a pattern that's really associated with the science of what I do. I'll typically hear, well, I heard you talk about carbs and the how common it is for us to start developing prediabetes, insulin resistance, even diabetes as we age into our 40s and beyond. So I also heard you say that, look, there's a book that was written by a fellow named Gary Taubes, Taubs, and it's called Why We Get Fat and What to Do About It. It's interesting that he takes 350 pages to get to this point, but I can give you the whole book in about 10 seconds.
okay.
We think as we get middle aged that we start getting heavier because we're eating more and exercising less. And the reality's similar, but maybe the opposite. We tend to be gaining weight and we're eating more because we're gaining weight. Now, that sounds a little bit weird until you think about it. Here's the thing, it's based on the role of insulin. Insulin actually stops our body from burning fat. As our body starts getting resistant to insulin, we start putting out more and more of it. As we do, we walk around with way too much insulin on board. We can't burn our fat anymore. So now we're starting to get hungry and we just eat more and more and more. And that's one of the new developments. It's scientifically, there's a lot of evidence now from the science just over the past 20 years showing that's exactly what's happened. Groups like, whether you're you're a fan of the CDC or not, the CDC's been saying this for 50 years. Over a third of us, especially by the time we reach age 60, over a third of us have dangerous levels of prediabetes and diabetes, but 90% have no clue. Well, there's new science which would say, well, yeah, that's sort of true, but it's a lot worse than that. JAMA Network, for example, came out with a large national study showing that this problem doesn't start at age 60, it starts at age 30. And by the time we're age 30, over half of us have dangerous levels of prediabetes and even diabetes. And again, 90% of us don't know it when we do have the problem. So that's a giant public health problem. It's far bigger than, and again, anytime you mention a virus like the pandemic, et cetera, you start raising hackles politically. I'm not making a political statement. I'm just stating the facts. Prediabetes and diabetes are a far, far bigger public health problem than any virus, any vaccine, any high blood pressure problems, any of the other problems that you can see listed. And it's still growing. It used to be just in countries that were what they called 20 and 30 years ago, first world countries, countries that, where humans had access to all the food they wanted. You didn't see that in the BRIC countries, Brazil, India, China, but you see that there now too, because in Brazil, India, China, you don't have nearly the problem with food access that you had 30 years ago. It's getting more and more limited to the African subcontinent. So the whole world is now way deep into this prediabetes, diabetes problem. So guess what? Number one cause of death, heart attack. Number one cause of disability, permanent disability, stroke. So I could spend my whole time just working on that. And I do spend a major part of my time just working on that global pandemic of prediabetes and diabetes.
Well, what about those who have not experienced a heart attack or a stroke or have not been diagnosed with a chronic disease? Do you or can you offer services to them?
You know, it's very interesting and exciting when I have a lot of patients who've said, you know, now I'm worried about my kids. Now that I know what you do, would you mind checking on my 25-year-old? And sure enough, about 2/3, 3/4, we find problems that that they did not know they had. Now, here's the thing. Here's what I do that's different from most docs. I don't wait until they have heart attack. I don't wait until they have diabetes. I go back and look at their metabolism on what it should be if it were perfect. And if you find a metabolic problem early, there's a lot more, it's a lot better to fix it before you get tissue damage. And that's the thing. In medicine so far today, we've always waited until there was tissue damage. You know, the heart attack and stroke are massive tissue damage. But, you know, even with, here's a couple of science statistics, and pardon me if they're a little bit too nerdly, but I'll explain what they mean in just a second. By the time somebody's diagnosed with diabetes, depends on the study you look at, but generally, it's between 1 and 2/3 already have diabetes eye damage. Now, when you think about that, what does that mean? It means two things. Number one, you ask a doctor, and most doctors will say, "Oh no, you don't get eye damage until you have full-blown diabetes." Okay, well, accept that for a second. Then that means 2/3 of the people had enough diabetes missed long enough to get damage to their eyes before they ever got diagnosed. The other thing it means is that, you know, and this is the reality as well, you start getting damage before you get this diagnosis of full-blown diabetes. Prediabetes and diabetes are the same disease. It's just that it's a matter of degree. If your blood sugar goes up to 199, technically you're still pre-diabetic. If it's 200, technically now you're full-blown diabetes. There's really no difference between 199 and 200 in terms of your body tissues.
Very interesting. Another topic, I understand that you collaborate with MSOs, management service organizations.
Yes. So you got a minute for me to talk about that?
Sure. Tell us a little bit about that.
So MSO is a generic legal term. For example, when you mention an MSO to a lawyer, quite often lawyers will think that's the management, that's the commercial management organization for a professional corporation. That's not really what we're talking about when we talk about doing MSO services. If you look in the managed care side or the fee-for-value side, here's what happens. Companies that are doing managed care or fee-for-value or taking financial risk based on people's health, then you're looking at companies that really have to make sure they do that prevention and primary care extremely well. They're not waiting till somebody has a heart attack to figure out that they had diabetes, for example. So what you'll tend to find with the large companies that do that, like Physician Partners, which I used to be the chief science officer for Physician Partners, teaching their doctors how to make these diagnoses back early when they were a metabolic problem and before you got tissue damage. There are other organizations in this space as well. Oak Street Health. Oak Street Health recently made the news. As of mid-February 2023, they just announced they're about to be purchased by CVS Pharmacy for $10.5 billion. There is a huge transition in healthcare, as I mentioned earlier, in this space, and MSOs are the organizational component that these companies use to achieve this work. Now, so an MSO it stands for Managed Service Organization. Mm-hmm. And what an MSO does is it works with doctors to help doctors learn how to do this fee-for-value, managed care, the financial side, as well as the technical medical side of knowing how to engage patients, get patients into the proper type of fee-for-value contract, work with the payers like Humana, Cigna, United to get a teamwork between Medicare, the payer, the doctor's office, and the patient, and get that to where the patient is maintaining great health, not going into the hospital. Medicare's now, as I said, saving 50 to 500,000 on hospitalizations. Mm-hmm. And then when that happens, Medicare comes back and says, okay, you know what? We're sharing that back with Humana and the doctor. So it gets the doctors into a position where they're doing the best thing for their patient, because their patient is no longer getting hospital level sick. They're staying healthy. Number two, the doctor is spending more time with the patient, more time, fewer patients. And number three, they're spending more time with their family, because the doctor gets off of that treat 'em and street 'em type treadmill where, mm-hmm. In fee-for-service medicine, doctors get stuck in this thing of, oh, you know what? I only get paid if I write a script. So let me bring Johnny in, pat him on the back, ask him how Sarah's doing, see if I can act friendly, see how quickly I can write a script, and then get back out and go to the next patient. That is what you see way too much in the fee-for-value world. This is a very different world. You slow down, you take half an hour, 2 hours. I just started one of these programs in Alabama last year, and it was a very fee-for-service world. And as I would talk to people about taking an hour with that initial annual wellness visit, they would say, somebody finally raised their hand, and they say, okay, I get it. So you spend 15 minutes with the patient, and then what do you do for the next 45 minutes? Talk about Alabama football?
Oh my.
So the answer was no. So then our first patient, we had an NP go in. We had the medical assistant and the other folks go in, get their work done, get the patient ready. The NP spent an hour with the patient, came back, presented the patient to the doctor and me. I'm just listening. I'm not coaching or taking over or anything. Then I go in with the doctor to see the patient. The doctor spends an hour with the patient, looks down at his watch and says, we've got a lot more we have to cover, and looks at me and says, I know we've spent 2 hours already, but we're just going to have to see him back next month to cover some of this other stuff.
Wow, it's a completely different approach. I'm hearing all that you can do for the patient, but it sounds like you can do a lot for the doctor too. Would you be interested in a part 2 where we go in depth and talk about what you can do for doctors in preventative medicine?
I would love to do that with our MSO, for example. So I took a lot of the stuff that I learned as the chief science officer for Physician Partners. Physician Partners is now they're the biggest, and in fact, I think a better competitor to Oak Street. I think their valuation is going to end up being higher. And it's because they do the work right. They train their docs, and I was a major part of that training, teaching docs how to, you know, when docs would come into our program, they would typically diagnose diabetes in 65-year-olds. You know, these are Medicare patients, about 5% of the time. And the reality is, if you're a doc doing this kind of work, you know that by the time we're 65, it's way over half.
Mm.
And sure enough, after a doc's been working in that environment for 3 to 5 years, they start getting up to like 30 or 40%. My goal, my work was to get them to recognizing that coming out of the blocks with those patients. So I took that kind of information. I developed a learning resource center. Doctors can now just sit down with that, learn anything and everything they need to know to function very well in the new new fee for value environment. And again, do better for their patients, keep their patients, profit from their patients, and get home to see their family, which is just not where it's been the past 30 years.
That sounds very interesting. Now, you mentioned YouTube. Can you tell me a little bit more about your offerings online?
Sure. So at this point, we're up to over 1,000 videos. You would think, after I did a couple of weeks worth of videos just because there was at least that much content. And I started reading a little bit about content planning early on when I started getting serious about YouTube. And the people that are, when they talk about planning, they tell people how to start a YouTube show. They say, sit down, think about your topic that you want to have for your YouTube environment, and write down 30 topics. If you can't write down 30 topics, it's not worth a channel. Well, again, you might think there's not 30 things to talk about in prevention, but I'm way over 1,000, and we have a system for planning our content development. And Jesus, the doctor I was telling you about, was laughing a couple hours ago when we were talking about it. He said, we're already booked into December, and this is just February. So there's a lot to talk about in this space. It all revolves around helping people avoid the bad things that kill them, that shorten their lives, that disable them, and maximize the things that help them live a healthier life.
So you do this through YouTube videos, but I understand you also have educational courses and digital classes people can take?
We do. So here's the thing. When you boil it down, there are some of the biggest disconnects in health and medicine have to do with diabetes, prediabetes, as I've already mentioned, but they also have to do with cardiovascular health as well. And so if you follow the medical research, here's another thing that's really clear. Some of my old comrades at Hopkins started this, and now research is coming out of Mayo and Harvard as well, indicating that not 10%, not 20%, but over 2/3 of the primary care doctors in the US, the supposedly best trained healthcare manpower group in the world, don't know how to diagnose prediabetes, let alone manage. So if you're depending on your doctor, which almost everybody does, to find the thing that's most likely to kill or disable you, which everybody does, then it's not exactly the same analogy as letting the fox guard the chicken house, but it's a similar analogy in that the people that you're depending on are not doing you the best service. Now, that may sound like some grumpy internet doc talking about other doctors not doing things right. But again, this is not me saying that. This is the science, the scientific evidence. And it's just unfortunate right now. It is improving. It will change, but medicine changes very, very slowly. It's going to be at least 30 years before we fix this problem. I've been, as I mentioned before, I've been way deep into medical education. I was a faculty at Johns Hopkins in medical education, and it's really clear why the wheels of medical education turn so slowly. So, most of us that are going into middle age now are going to be dead by the time healthcare gets this problem fixed. So the courses that I have are courses where, sure enough, 2 hours, and you can know more about insulin resistance, prediabetes, diabetes than your doctor does. 2 hours, and you can know more about cardiovascular inflammation than your doctor does. 2 hours, and you can know more about how to evaluate plaque. If I've heard it once, I've heard it hundreds of times. Hey, doc, my brother had a heart attack, and I'm just afraid that I've got enough of his genes. Can we just do a stress test? Well, a stress test is not the right thing to do. Stress tests don't predict heart attacks. In fact, it's really clear. About 2/3 of the people that have heart attacks do so because they have plaque, but it's not the kind of plaque that would have shown up on a stress test. Do you remember Tim Russert? He was
No.
a big news guy, Face the Nation or Meet the Press. I can't remember. It was one of those two. And he was the longest running host of that. He was very well known. He was known for taking politicians or folks, that were in the press at that point and basically showing them what they said a year ago and then showing how that's not what they're doing today. He is the poster boy, the poster child for passing a stress test with flying colors and then dying from a heart attack. And that's exactly what happened to him. He was a runner, but he had some inflammation going on, and he passed his stress test just fine with flying colors. And he said, well, I'm glad I'm okay. Went in to do the taping for one of his shows, looked up to his producer and said, hey, what's happening? Killed over dead.
Wow. So it sounds like you have a lot to offer to patients, but also to doctors. We appreciate this helpful and interesting information, and we look forward to a part 2 when you go in depth on what you can do for doctors.
Well, thank you very much again for the opportunity to talk about what I do. As you can see, I'm very passionate about it.
Yes, well, thank you, Dr. Brewer. And if you look at the screen, if you're interested in learning more information about Preventive Health or Dr. Brewer, here is the contact information, website, and also finding them on social media. So thank you for listening today. This is World Medical Elites, and we hope that you'll subscribe and join us again soon. Thank you.